Hi, I'm Rebecca Dibiase, and I'm a third-year medical student at Johns Hopkins University, and I'm excited to tell you about my scholarly concentration project. My project is called Laryngotracheal Manifestations of Autoimmune Disorders, and I was part of the clinical research subset of the scholarly concentrations. So just for some background, it's widely known that autoimmune conditions cause scarring and debilitation in many different body systems. This is caused by the chronic inflammation that these autoimmune conditions create. Up to 55% of patients with autoimmune conditions have laryngeal symptoms that they manifest with. There's only a small amount of research that currently exists, and it shows that there are trends in the airway symptoms that different autoimmune diseases present with. However, this research body is very small, and so with our scholarly concentration project, we hoped to solidify this connection between the fields of laryngology and rheumatology. This just illustrates the various systemic manifestations of different autoimmune conditions. These are two examples, Sjogren's syndrome and Crest syndrome, which is a subset of scleroderma. As you can see, in scleroderma, for instance, the laryngeal manifestation tends to be esophageal dysfunction, namely acid reflux and decreased motility of the esophagus. This shows a picture of normal vocal cords on the left, and then vocal cords in a patient with rheumatoid arthritis in the right. The nodules you see in this picture on the right are called bamboo nodules, and these are a common manifestation of rheumatoid arthritis. This is a patient with Wegener's granulomatosis, which is currently known as GPA. As you can see, there are diffuse granulomas throughout the larynx, and then on the right you see a histologic slide that shows that these granulomas are non-caseating granulomas. So for our study, we hope to identify patterns in the laryngotracheal manifestations of these different autoimmune conditions. For our methods, we based our project off of a similar study model that we found by Matsuoka and Harris. These researchers conducted a study in which they looked at autoimmune diseases in the inner ear. So we conducted a billing search from 2002 to 2012 of patients who had been seen in the laryngology department at Johns Hopkins and who had been subsequently billed for their autoimmune conditions. The 5 autoimmune conditions we chose to look at were rheumatoid arthritis, GPA or granulomatosis with polyangiitis, sarcoidosis, Sjogren's syndrome, and scleroderma. We collected a number of variables from each patient's records. These we subdivided into first demographic data. This included age, gender, ethnicity, BMI, smoking status, and what sort of systemic immunosuppressants the patients were receiving. We then looked at the way these patients presented to their laryngologists. So we looked at the chief and secondary laryngeal complaints they had, any associated symptoms they presented with, and whether or not they had acid reflux as a comorbidity. And finally, we looked at the diagnosis these patients received and their treatment plans that they received when they left their laryngologist. For diagnosis, we looked at vocal cord motion impairment and findings. We also looked at whether these patients received a new autoimmune diagnosis based on their laryngeal findings. We looked at the findings on laryngoscopy and on laryngeal biopsy. We determined the laryngeal diagnosis for these patients and whether they had a history of laryngeal surgery. And then we also looked at comorbidities and their final treatment plan. For data analysis, we used Microsoft Excel as well as Stata, and we conducted chi-squared and ANOVA tests for all the patients and their variables. So for our results, we found 124 laryngology patients. And just of note is that the only results we reported and the only results we'll report in this presentation are those that have a p-value of less than 0.05. So therefore, all the results you'll be seeing are all significant statistically. So as you can see in this pie chart, we had an almost equal distribution of all the different autoimmune conditions in our study population. First, for demographic results, we looked at the gender of the patients we found. So as you can see, red is female, blue is male. The large majority of patients with autoimmune conditions tended to be female. The only exception was GPA, and this autoimmune condition had a pretty much equal prevalence of males and females. We also looked at race differences in the different conditions. Sarcoidosis was more common in African Americans, and all of the rest of the autoimmune conditions we looked at were more common in Caucasians. Just to note, all these demographic data that we found are already widely known in the literature, so our study just validated a lot of the demographic trends that most physicians are already aware of. We also looked at the different immunosuppressants that many patients were taking with different disorders, and as you can see here, there were certain different drugs that were prescribed to patients based on which underlying autoimmune etiologies they had. So for illness presentation, we found that the three most significant chief complaints these patients had were dyspnea, which means difficulty breathing, dysphonia, which means difficulty speaking, and dysphagia, which means difficulty swallowing. So in the graph below, you can see that for patients with rheumatoid arthritis, GPA, and sarcoidosis, most patients had either dyspnea or dysphonia. For patients with Sjogren's, most patients had dysphagia or dysphonia. And for scleroderma, there were an almost equal number of patients with all three different chief complaints. We also found that the most significant secondary complaints patients presented with tended to be sinonasal complaints, otological complaints, or dysphonia. Now, dysphonia was one of our chief complaints as well. So we found that some patients had dysphonia as a chief complaint. That's the main reason they came to see their laryngologist, while some patients came for another reason and also mentioned that they had mild dysphonia or that they had developed dysphonia after their other chief complaint. So in the latter two cases, we classified dysphonia as a secondary complaint rather than a chief complaint. As you can see, patients with rheumatoid arthritis had an almost equal distribution of all three secondary complaints, whereas the patients with the rest of the disorders were most likely to have sinonasal complaints, and then second most likely to have otological complaints. We also noticed that a lot of patients with autoimmune conditions had comorbid acid reflux. So this was either acid reflux diagnosed by their laryngologist, or it was GERD diagnosed by a GI physician or another kind of physician. So of note is that actually 100% of the patients with scleroderma, so all of our patients with scleroderma, did have acid reflux symptoms, and we'll explain why that's important in the next slide. So perhaps our most interesting and significant finding relates to the diagnoses these patients received from their laryngologist. The three most significant diagnoses noted were tracheal stenosis, subglottic stenosis, and chronic laryngitis. The picture I have here shows laryngotracheal stenosis. So as you can see, the airway in this patient has been significantly narrowed, and therefore it's going to be difficult for this patient to either breathe, swallow, or speak. In the graph, you can see that there are very significant trends within each different autoimmune condition based on the diagnoses the patients received. Patients with rheumatoid arthritis were equally likely to have all three of these diagnoses. Patients with GPA were most likely to have subglottic stenosis, and patients with sarcoid and Sjogren's were most likely to have a different diagnosis other than these three diagnoses. Many patients with scleroderma had chronic laryngitis. If you remember, all these patients had acid reflux, so we hypothesized that these patients developed chronic laryngitis because their reflux irritated their larynx chronically, and therefore their larynx eventually developed this significant inflammation. Finally, we looked at the different therapies these patients received. As you can see from the blue bars in the graph on the left, all of our patients, or not all of our patients, but nearly all of our patients in all different categories were either continued on the immunotherapy they were already receiving or received new immunotherapy after they visited their laryngologist. Patients with rheumatoid arthritis, GPA, and to a lesser extent sarcoidosis were the most likely to receive surgical interventions. So this means that patients with these different autoimmune etiologies tended to have the most significant laryngeal manifestations, and therefore they were most likely to warrant surgical intervention. The picture we have here is the same picture you saw from the last slide, and then this is the same patient after the patient received a dilation via surgical intervention. So as you can see, this patient's larynx has been opened up significantly, and their symptoms have most likely improved significantly also. Finally, a lot of our patients received voice therapy, especially our patients who had scleroderma. So it's interesting to note that at Johns Hopkins, there's a tight connection between the voice therapy department and the laryngology department. So many laryngologists are aware that voice therapy is a good treatment option, and they tend to refer more patients to the voice therapy department. So it would be interesting to conduct this study at another institution and to determine whether this still holds true even if these two departments aren't as closely connected. Finally, we looked at the percentage of patients who had tracheostomy tubes. So the graph on the right shows our results for this category. Tracheostomy tube was often the last resort. So for patients who had really severe symptoms, who didn't respond to any other treatments, they were forced to receive a tracheostomy tube. So as you can see, patients with RA, GPA, and sarcoidosis, who were, in our previous graph, the most likely to receive surgical interventions, were also the most likely to receive tracheostomy tubes because their manifestations were often the most severe. So in conclusion, autoimmune disorders tend to present with different laryngotracheal manifestations and warrant different forms of management. There are many different ways we can differentiate laryngeal disease. First, we can look at demographic data and other general characteristics. We can also look at the patient's chief complaints, whether or not they have acid reflux, and the associated symptoms they have. Rheumatologic conditions can also impact laryngeal diagnosis and treatment plan. And finally, the laryngeal pattern can help give us clues to the autoimmune disease underlying it. So we hope this will help laryngologists in the future refer more of their patients to rheumatology appropriately. Some limitations of our study were that it was a retrospective study, so we were unable to look at variables that hadn't been recorded initially. In addition, our billing search likely missed some patients who weren't billed for the very specific keywords that we searched for. And finally, video stroboscopy data of the patient's vocal cords were recorded for most of the patients, but not for all of the patients. In the future, for the video stroboscopy data that we do have, we would like to have experts re-review them. We also would like to conduct secondary statistical analyses, and we also want to examine and figure out how to educate clinicians about our findings so that they can appropriately apply them in a clinical setting. Finally, I'd like to thank a few people. I'd like to thank all of the patients who contributed information to this study. I'd also like to thank Dr. Hillel, my primary mentor, and Dr. Wigley, my secondary mentor. Dr. Gadkari conducted our statistical analysis, and he was actually a medical student at the time, and he's now a physician. And then Dr. Sozia, who's given me the wonderful opportunity to speak to all of you. And finally, Dr. Reller and my scholarly concentration peer group, who gave me valuable feedback all along the way. So thank you.